Nick, tell me about the case last night.
So this is a 70-year-old man, well known to the ENT service for head, neck, laryngeal cancers, with a recent CT showing significant head and neck masses, who was a pre-hospital 911 call for respiratory distress. And I was called by one of our staff, 15 minutes notice, got in before the patient, and were able to set up for a number of different airway plans, including an awake look with a flexible intubating scope, surgical airway, video assisted flex scope, and direct laryngoscopy. We simultaneously put calls out to anesthesia resident staff as well as the ENT resident staff to get there as quickly as possible. When the patient arrived, he was sitting upright. He had a maximum O2 saturation of 80%. It was cool and mottled and obviously very sick. He was mentating. He was able to participate, and very quickly we established goals of care, and he did wish to be intubated, and that was confirmed by the patient's wife, who was with him in the ambulance. He completed an airway assessment. He had limited mouth opening, easily a Mound-Patty 4, had significant anterior neck masses, which essentially made identifying any airway structures on the neck impossible. And so we made the plan to begin topicalizing him, initially with the aerosol and with the lidocaine gel on the tongue.
Just stop for a second there, Nick. Who was there at the time in the room to help?
As we were beginning topicalization for our wake look, in the room was one of our emerge physicians, myself, and our ED critical care paramedic, and a couple of the emergency department nurses. And then at some point through the topicalization process, the ENT junior resident arrived, and then shortly thereafter the ENT staff. The anesthesia resident arrived at some point in there. I'm not really sure when. And so what we did was, despite his hypoxia, the patient remained cognitively intact and very cooperative, such that he actually instructed me to use his right nair for a flexible scope. We loaded the flexible intubating scope with a 6.0 endotracheal tube. We were aware from a CT that he had done a couple of days ago that he didn't have a lot of space for the passage of a tube. And so with the ENT staff and our department staff at bedside, we did a flexible scope through the right nair, down through the nose, and down towards the airway. Most structures were entirely unrecognizable. Significant tumor burden, significant tumor mass that was down there. We were able to identify our retinoids briefly, and really only by getting the patient to sniff in as hard as he can to try and open up his airway as much as possible. We were able to identify what we felt was an airway, and a decision was made between us and in conjunction with the ENT attending physician at the bedside, that given the patient's level of hypoxia, that he needed to be intubated right now. And so we used the flexible intubating scope to pass down through his glottic opening, which was, as I said, anatomically largely unrecognizable, and then really only knew where we were once we were in the trachea and could see tracheal rings. The caliber of his glottic inlet was not much different than the caliber of the scope, so half a centimeter. The clinic note from the week before had suggested that he had significant stridor at rest, and in retrospect now he didn't, probably because he just wasn't moving enough air. We were able to get the scope down into trachea, identify tracheal rings, and then advance a 6.0 endotracheal tube over top of the flexible intubating scope and down into the airway. It was difficult to pass. I think it's just because of the tumor mass that was there and the size of the glottic opening, but I think it was done relatively atraumatically on first attempt. Patient tolerated it really well. As soon as tube was in, it was held in place by myself. I wasn't going to let go. Flex scope was removed. Our first confirmation was seeing the end of the tube at tracheal rings. We did a colorimetric CO2 detector to confirm placement as well. Hooked him up to an ambu bag and began to provide 100% FiO2, administered ketamine and rock to really take control of his breathing, and then hooked up continuous end tidal CO2 tracing to ensure that our tube was actually in the right place.
And Nick, you mentioned that when the ENT staff, and when you say we, you were doing the scope.
Yeah, I did I did the entire scope.
And this is with the ambu scope.
So this is the disposable ambu A3 scopes.
Right. And when you're feeling neck, and the ENT surgeon who was at the bedside felt the neck, what did he say?
So our usual, part of our usual preparation for any difficult airway would be to assess for a surgical airway, and what we'll often do is identify landmarks before doing anything and draw an X on the patient's neck over where their cricothyroid membrane should be. And in trying to do that and trying to landmark, I was really unable to appreciate any anatomical landmarks, and the ENT attending physician at the bedside essentially just shook his head and said, "It's not going to happen."
Anyway, so listen, great case. What was nice is that you, as an Emerge resident slash fellow, were given the respect by ENT and anesthesiology, and did an incredible job and saved this guy's life. That's a bigger issue whether how he's going to do from here. But anyway, thanks for the story, and thanks for being you.
Thanks.